God morgen og velkommen til Forum for teknologi og utviklingssamarbeid sitt frokostmøte. I dag skal vi ha en del spennende foredrag under titlen «Hvordan kan innovasjon og eHelse bidra til bedre helse i lav- og mellominntektsland?» Formålet med Forum for teknologi og utviklingssamarbeid er at vi skal være en arena for debatt og informasjon. Og FTU skal fremme teknologi og innovasjon i utviklingssamarbeid ved å skape bevissthet og dele kunnskap og etablere samarbeid. Og det er det vi gjør i dag, å ha et nettverksmøte med spennende informasjon, spesielt i forhold til bærekraftsmål nummer 3. For vi skal fremme bærekraftsmålene og se på teknologiens potensiale for å nå bærekraftsmålene. Forum for teknologi og utviklingssamarbeid er en tilknyttet Tekna-organisasjon. Programmet i dag er at vi har en liten velkommen med meg som heter Tone Ødro, jeg er fra Forum for teknologi og utviklingssamarbeid. Og så kommer et interessant foredrag RT-lamp for covid-19 av dr. Nabil Kara. Og så har vi Clinic Box med Serina Søyland Bru. Og til slutt så har vi Better eHelse med forsker Konstantinos Antipas fra Sintef. Og så har vi en diskusjon med spørsmål etterpå. Vi samler opp alle spørsmålene etter hver innleder er ferdig, og dere kan ta noen spørsmål hvis innlederne ikke bruker opp tiden sin. Eller så kan vi samle opp spørsmålene og ta de til slutt. Dere som sitter i salen kan rekke opp hånda for å stille spørsmål, og dere andre kan stille spørsmål via Slido, som er sendt på e-post, eller dere kan bruke hashtag FTU på mobilen. Seminaret det tas opp og legges ut sammen med presentasjonen i etterkant, og dersom du tar ordet og stiller spørsmål, vil dette også bli en del av opptaket. Evaluering sendes etter hvert seminar til slutt, fordi vi vil veldig gjerne ha tilbakemeldinger på hvordan dere opplever seminaret. Så da ønsker jeg å introdusere den første foredragsholderen, Nabil. Vær så god, ordet er ditt.
Thank you, Tina, for the introduction, and thanks for the invitation. My name is Nabil Kara. I'm a research associate at the Department of Microbiology at Umeå University in Sweden. I'm also the CEO for a Norwegian biotechnology startup just established in 2021 based in Oslo. The title of my presentation and for my project is molecular testing for COVID-19 in low resource settings. The pandemic of COVID-19 started like 2.5 years ago and is still going on. The total number of confirmed cases is more than 500 million all over the world, and the total number of deaths is around 6 million in the last 2.5 years. The pandemic is still ongoing, so in May, in the first 2 weeks of May this year, we are talking about 2.5 million, more than 2.5 million every day of new cases confirmed by lab testing. Our response plan against COVID-19 in the US or here in Norway, in Europe, etc., it needs to meet 3 main challenges. First, we need to provide enough vaccines. Second, we need to provide enough masks and personal protective equipment. And third, we need to provide enough testing. And that's where we are really concerned. According to the literature, there is a huge gap and shortage of testing in many parts of the world. Even when we are talking about Europe, even when we are talking at the level of Norway, for example, there are some inequity in the access to testing. Here I just put some few recent publications, including one from Switzerland, one from the Bureau. In general, we see that there is a huge gap and there is a need for more access for people to to accurate and affordable testing. Now, the status now that we have two main approaches for testing. You have the PCR, and now we are talking about cities, we are talking about hospitals, and we are talking about equipment and human expertise. So we need all these things to get a PCR result, which is the best. This is the gold and reference standard method to confirm that we have COVID-19. On the other, at the other end, we have the rapid tests. In Norway, I think we can see that it's everywhere now. When we go to the mall, they even give you for free, just take and go and test yourself, which is excellent. It's very good for screening, but the accuracy of this test is still not, it has some limits in the accuracy of the tests. So our idea actually is to go to something in between. We need to combine the accuracy of the PCR related tests with the rapidity and the affordability of the rapid tests. Our idea that maybe we need to go for like some kind of primary health care clinics in low and middle and lower middle income countries. Or even like here in Norway, if we are talking about clinics in the countryside, we are talking about airports, we are talking about platforms in the middle of the sea, for example. We want something without the need for expensive equipment, without the need for a huge human expertise, and something that can be, we can get the result within maximum 1 hour. That's our target. There are certainly several research groups all over the world working on this. If you search in PubMed, you will see like a lot of people trying to come with new ideas, 3D printed devices, or like some simple tubes that you can use to detect for COVID-19. For us, we want to go for more like paper-based device. Our idea is simply to take the sample from the patient, use any commercial Lysis tube to lyse the sample and inactivate the virus. And then there are like the ability of filter paper to capture the DNA of bacteria or RNA of viruses, such as COVID-19. That's what we are like interested in. Are we able to use this feature of several types of filter paper to capture the RNA of the virus? And then the second thing that we want to do is to add primers in the filter paper. And when I say primers, these are like short sequences that are enable us to amplify the RNA or the DNA. Those are the ones that make the test specific. And this is why our test will be more accurate than the usual rapid tests. So what we are trying to assess now, are we able to put these primers on the filter paper, and at the same time, the filter paper can be used to extract the RNA from the virus in one step. And then it's easy. We get rid of the absorbent pad, and then we have a sheet that we can put it on any also commercial hot plate, and then we add the RT-Lamb master mix. So when I say RT-Lamb, it's another method that will help us to amplify the RNA of the virus. Since we have the primers already in the filter paper, we will go for a specific region in a specific gene in the virus. Our results will be as accurate as the PCR method. We are still in the beginning. This method will take at least 45 minutes to amplify the RNA. So it's not a rapid test. You will not get the result in 5 minutes. However, you don't need expensive equipment. You don't need expertise, and you somehow reach a level of accuracy that is as accurate as the PCR standard method. Now we are still in the technical first phase of the project. So we are still trying to test the if we put the primers, are we able to extract the RNA or not? And if this will affect the specificity, the sensitivity, the limit of detection, and also we care about the cost of this method and the stability of the reagents on the filter paper. So our idea that this RT-LAMB method is widely used in the tubes, in the laboratories. We want to move it from tubes to filter paper, and we want to move it from the lab to primary healthcare center or mobile clinic, or even on the border gates, etc. At the end, once we get to confirm or to finish the technical study, our idea also to go for either, or maybe we will go to the two approaches actually. So we want to make one compact stand-alone device where you can combine all the things. You can combine a micro heater / a detection unit in one device that can be used for each test. The other option, which is more interesting and more tailored actually to meet the low resources in many countries, is not to do one compact device, but to depend on off-the-shelf devices. So are we able to adjust many of the commercially available devices, put them together, and what we need, we just need a hot plate, and we need a way to detect the color of the test or the fluorescence of the rest of the test. It depends on which technique we use. We think that we will do both. This is still waiting until we finish the results of the technical study. The other thing that is very important for us, that once we confirm, once we are happy with the results of our technical study, it's not only COVID-19. The pandemic of COVID-19 is certainly important. It's going on, and we need to continue testing and continue screening. However, we are talking about tuberculosis. We are talking about malaria. We are talking about antibiotic-resistant bacteria, hospital-acquired infections. We are talking about not only humans. There are like the pathogens for animals. There is the fish industry in Norway. It's a huge thing. And to detect these fish pathogens, that would be, if we are able to go to the fish farm and do the test in the fish farm instead of taking the samples to the lab, that will give a huge access for many farmers in many isolated parts of Norway or other parts of the world to do the test. That's my talk. I would really like to thank Centif, mainly Konstantinos Antipas, Francisca, Arne, and Ingemar. I would give a huge thank to our colleagues in Jimma University in Ethiopia, Gogsha and Ficado. Big thanks to Innovation Norway. Innovation Norway is supporting this project. So many thanks to Vidar and Per. And also many thanks to ShareLab. ShareLab, it's in Forskningsparken, Oslo Forskningsparken. And now we are also having like agreement with them to do the research and part of our tests in their labs. So thanks, Marius and Espen. Thank you, Tina.
Thank you very much, Nabil, for a very interesting presentation. It was so far, there were no questions in Slido. Are there any questions from the audience? I have one question, Nabil. Where are you going to test you are now going to test in a laboratory? Are you going to test in some specific countries or in some specific regions or areas?
Yes. So we have our partners at Jimma University in Ethiopia, but yes, we also have, we made some agreement with UNDP.
Yeah.
So they will provide us access to do the tests in Zambia. This is not confirmed yet, but I think we are going to do 2 pilot studies after we finish the technical study and the prototyping, and one will be in Ethiopia and one will be in Zambia.
Excellent, excellent. I would like to ask you a little bit more at the end about the UNDP collaboration. It's very interesting to hear. So far, thank you very much.
Thank you.
So the next presentation is from Serina, and she's going to talk about Clinic Box, and this will be in Norwegian. So we have a mixture here today, Norwegian and English. Så neste foredrag på norsk fra Serina. Vær så god, Serina.
Ja. Tusen takk for at jeg fikk lov å komme her i dag. Mitt navn Serina Søyland Bru, og jeg med i teamet for Clinic Box i lag med disse 3 karene her. Olivier Monkuta. Han ingeniør i medisinsk teknologi og gründer. Og han har, som dere ser, valgt sin egen titel her i dag. Og så det brødrene Hvordan og Jonathan Kongolo. Roland han lege, og Jonathan dataingeniør. Og vi ideen til Clinic Box, den vokste fram utifra en uro over de store forskjellene i verden når det kommer til lege- og helsetilbud. Så for å illustrere litt disse forskjellene, så har jeg sammenlignet Norge med Tanzania her i forhold til leger per 10 000 innbyggere. Det ikke tilfeldig at jeg sammenligner med akkurat Tanzania. Det kommer jeg frem til litt senere i presentasjonen. Men som dere ser, så det rundt 50 leger per 10 000 innbyggere i Norge. Og det vil si at en lege har ansvar for ca. 200 pasienter. I Tanzania derimot så det bare en halv lege på 10 000 innbyggere, som vil si en lege på 20 000 mennesker. Og det gir jo selvfølgelig ikke noe mening å se for seg at en lege skal rekke over 20 000 mennesker. Og nå det jo også sånn at i byene der sykehuset og klinikkene ligger, så det en større legetetthet enn dette her. Men det vil jo dessverre også bety at ute på landsbygda, der faktisk 70% av befolkningen bor, der det jo mye færre leger enn en på 20 000, som ganske kritisk. Leger, de bor jo ikke på landsbygda, for de studerer og flytter til byene for å jobbe på større sykehus og klinikker. Og derfor det en stor legemangel på sykehus, dessverre. Eller på, ja, landsbygda i mange land. Ja, mangel på leger og helsetjenester, det har store konsekvenser for liv, trygghet, stabilitet, utdanning og økonomi. Og i Maslows behovspyramide, som vi ser her, så blir alle disse nivåer påvirket av helse. Og tilgang til god helsehjelp, det ikke bare et grunnleggende menneskelig behov, men det også en forutsetning for utvikling og vekst. Og det ikke uten grunn at bærekraftsmål nummer 3, som denne samlingen her tar utgangspunkt i, at de har med både god helse og livskvalitet i samme setning. Dette henger sammen. Vi i teamet, vi har alle bodd lenge og oppholdt oss i forskjellige østafrikanske land, og vi har enten erfart selv eller observert konsekvensene av manglende helsehjelp på nært hold. Resultatet ofte at sykdom eller skade, som med rett diagnostisering hadde vært ganske enkel å behandle, forblir ubehandlet eller feilbehandlet, og dermed forverret. Den hopper videre uten at jeg vil. Den åpenbare løsningen på legemangel jo selvfølgelig å utdanne og sysselsette flere leger. Men dette en kompleks og tidkrevende prosess som involverer både økonomi og politikk og infrastruktur, og som vi som enkeltindivider har vanskelig for å kunne påvirke. Og mange liv vil bli rammet før alle disse tingene på plass i et land som Tanzania. Derfor det viktig å finne alternativer og gode hjelpemidler til å håndtere den akutte legemangelen som påvirker mennesker her og nå. Tema for denne samlingen her hvordan kan innovasjon og eHelse bidra til å nå FN sine bærekraftsmål om bedre helse for alle. Og vårt svar på dette, som et bidrag av mange, ideen eller løsningen som jeg har valgt å kalle klinikkboks. Klinikkboks som ordet tilsier, en klinikk på boks. Den liten nok til at den kan bæres på armen eller flyttes rundt på motorsykkel i områder hvor det mangel på leger og helsepersonell. Boksen inneholder de viktigste måleapparatene for å diagnostisere og de vanligste sykdommene og plagene. Og den kan blant annet måle blodtrykk, oksygen, respirasjon, temperatur, blodsukker, urin og CRP. Og ved å for eksempel måle CRP på en pasient som har feber, så kan en avdekke om det behov for antibiotikabehandling eller ikke. Noe som veldig viktig i en verden som står overfor veldig store utfordringer i forbindelse med antibiotikaresistens, for eksempel. Så ved å kunne avdekke at det for eksempel ikke behov for antibiotika, så vil jo pasienten både spare penger og feilbehandling, eller slippe feilbehandling, og verden slipper et unødvendig tilfelle av antibiotikabruk, og legen kommer et steg videre i å gi pasienten rett diagnose. Uten denne målingen så kunne en typisk respons vært, når en person får feber, at den hadde gått på apotek uten resept og fått tak i antibiotika og selv medisinert seg med dette, når egentlig den rette behandlingen kanskje hadde vært å få malariamedisin. Klinikkboks ikke bare en boks med forskjellige måleapparater. Det også en digital enhet som koblet til en lege på en klinikk eller et sykehus. Og det kan være et sykehus i en naboby, eller det kan til og med i teorien være fra et annet land. Det ikke begrenset av geografi. Helseagenten, som den personen som faktisk har boksen fysisk og opererer boksen og tar den med seg, det kan være en helsefagarbeider eller en sykepleier eller en annen person som har fått opplæring i boksen sine funksjoner og hvordan måleapparatene brukes. Det likevel legen som følger med på avstand, som har det endelige ansvaret i diagnostisering og utredning av pasienten. Med direkte oppfølging så kan legen følge med gjennom lyd og bilde på en skjerm og kommunisere direkte med pasient og gi råd til helseagenten. Og resultatet av målingene blir registrert i klinikkboksen og blir sendt til legen, sånn at han eller hun kan gjøre en like god vurdering av pasienten som om møtet hadde vært fysisk. Målinger, diagnose, resept og behandlingsråd og all den informasjonen der blir journalført i et sikkert og digitalt journalsystem. Klinikkboks sin hovedfunksjon å gi mennesker i fjerntliggende strøk den samme tilgangen på kvalifisert legehjelp som folk i byene, og for å kunne få tilgang på legeråd, helsekunnskap og rett diagnostisering. For veldig mange sykdommer i verden og i afrikanske land livsstilssykdommer som diabetes og hjerte- og karlidelser. Og i mange tilfeller så vil kostholdsråd eller råd om spjelking eller opptrening etter skade eller sårstell eller behandling med brannskade. Alle disse rådene kan gis digitalt til pasient, som da vil få korrekt informasjon om hvordan han eller hun skal handle selv for å bli bedre. I andre tilfeller vil det jo være behov for medisiner, og disse kan pasient i veldig mange tilfeller kjøpe fra lokale apotek, som vanligvis mye mer tilgjengelig enn diagnostiserende klinikker og sykehus, som ofte mye lenger vekke. Men selvfølgelig, det jo også tilfeller der det blir identifiserte behov for nærmere utredning eller behandling ved sykehus. Og det først da det blir nødvendig for pasient å foreta denne lange og kostnadskrevende reisen til sykehus. Men med klinikkboks så vil mennesker i grisgrendte strøk slippe å gjennomføre denne lange reisen i situasjoner der det ikke nødvendig. Noe som energi- og kostnadssparende for både enkeltmennesker og for de offentlige helsetjenestene i utviklingsland. Klinikkboks kan også brukes av internasjonale helse- og bistandsorganisasjoner som jobber i krigs- eller katastrofeområder, der tilgang til medisinsk utstyr eller helsefasiliteter begrenset. Så hva skjer fremover for oss? Vi har mye spennende i vente, og her kommer grunnen til at jeg sammenligner Norge med Tanzania, fordi vi har altså fått helsemyndigheten i Tanzania. De har signert på en partneravtale for testing av klinikkboks sin prototype. Og denne testingen skal foregå på Zanzibar i samarbeid med Mnazi Moja Hospital, som også faktisk samarbeider med Haukeland sykehus. Og leger ved Mnazi Moja, de skal være med og teste prototypen i samsvar med lokale behov for telemedisin og helsetjenester for avsidesliggende områder i landet. På lengre sikt så blir det jo skalering og kommersialisering av klinikkboks, sånn at enda flere kan benytte seg av dette verktøyet. Så klinikkboks jo fremdeles ganske i startfasen. Og vi veldig formbare og interesserte i tilbakemeldinger og råd og samarbeid og innspill og alt det som Og hvem vet, plutselig så kunne den RT-LAMP-metoden som nettopp ble presentert, blitt en aktuell integrert del av klinikkboks. Eller, som vi skal høre snart om prosjektet Bedre eHelse, det kan potensielt bli en nyttig samarbeidspartner eller rådgiver i forbindelse med vår utvikling av eHelse-systemet da. Og kanskje det noen som har fulgt med her i dag, som har tanker eller innspill. Det i alle fall veldig velkommen for oss. Fordi som temaet litt i dag, så det jo både innovasjon og samarbeid som må til for å nå bærekraftsmålene. Så som en avslutning, oppsummering, så kan jeg prøve å svare på hvorfor klinikkboks en boks utenfor boksen. Og som jeg har prøvd å illustrere her i sliden, så ser en at sykehuset, det på en måte boksen, der den har begrenset kapasitet, men klinikkboksen gjør at den når ut til flere mennesker da. Som sagt så bor 70% av befolkningen i Tanzania på landsbygda, langt vekk fra sykehus kanskje. Så klinikkboks frigjør lege og pasient fra den geografiske begrensningen, som en ellers bundet av. Den lagt for de som faller utenfor dekningsområdet for offentlige helsetjenester. Det en klinikk på boks, som kan bæres under armen. Det jo litt uvanlig. Og den legger til rette for sikker og nøyaktig og tilgjengelig helseinformasjon i en digital helsejournal i stedet for sårbare håndskrevne notater i en skuff som plutselig kan forsvinne. Så det var det jeg hadde i dag, og satte som sagt pris på innspill og spørsmål, enten nå eller senere. Ja. Takk for meg.
Tusen takk, Serina. Kjempespennende å høre fra den ene gründeren til den andre gründeren. Og nå skal vi over til EU-prosjekter snart, men før du går, hvor langt har dere kommet? Har dere elementene inn i klinikkboks, eller de på skissebrettet, eller har dere testet ut noe av det her hjemme i Norge, eller andre steder?
Vi har lagt en førprototyp, kan jeg kanskje kalle det, der vi har samlet de forskjellige måleapparatene og faktisk bare festet de sammen, koblet de sammen. Og det var dette som ble tatt med til Tanzania, fordi noen foretrekker håndfaste, synlige bevis på hva ting kan bli, da. Så vi har en sånn prototype, men det endelige målet er jo en enda mer kompakt og integrert, solid og brukervennlig enhet, da.
Ja, men dere har allerede alle
Vi har-
elementene
ja.
som dere kan bruke som en prototyp.
Absolutt. Så vi har den klar, og Tanzania er klar for å begynne å teste. Så det gleder vi oss til.
Ja, veldig spennende. Det har ikke kommet noen flere spørsmål på chatten, så det er tydelig at dere gjør ting helt klart og enkelt for tilhørerne. Er det noen i salen som har spørsmål? Kostas?
Gratulerer, det er et veldig interessant prosjekt og løsning. Spørsmålet mitt er om dere har hatt noen utfordringer med å begynne å jobbe i Tanzania. Var det noen sånne byråkratiske problemer? Var det noen hindringer i lovverket som begrenset dere?
Nå var det ikke jeg som reiste til Tanzania og presenterte klinikkboksen, så det kan godt være at det var mer utfordringer enn det som jeg har fått kjennskap til. Men mitt inntrykk er at en har vært veldig positiv og engasjert. Og selvfølgelig når vi reiser ned til Zanzibar og starter, så er vi forberedt på at det kan dukke opp selvfølgelig reguleringer og ting som vi må ta hensyn til, men det er vi forberedt på å prøve å tenke ut mest mulig løsninger på forhånd, da.
Tusen takk.
Takk.
Veldig spennende.
Skal dere ha?
Så har vi gått da, som jeg sa, fra gründervirksomhet til et EU-prosjekt, hvor land i Europa samarbeider med land i Afrika. Og vi har nå vært innom mulig prototyping i Etiopia, Zambia og Tanzania. Og nå skal neste foredragsholder introdusere enda flere afrikanske land som samarbeider med europeiske land. Så vi har Konstantinos Antipas fra Sintef Digital Avdeling Helse, som skal snakke om bedre eHelse. Vær så god, Kostas.
Takk, Tone. Jeg skal bytte til engelsk, men jeg kan ta selvfølgelig spørsmål på norsk etterpå. My name is Konstantinos Antipas. I'm working at Sintef Digital as a researcher, and I also have a 20% position at the Norwegian Center for eHealth Research that is in Tromsø, and I'm the coordinator of Bedre Health project. As Tune presented, the Bedre Health project is an EU-funded project from Horizon 2020, and it's a coordination and support action, which means that it's not its main focus is not on research, as many other Horizon 2020 projects are, but is more to build a network and create opportunities and coordinate some actions, even prepare the landscape for future research projects. Our projects, unlike the other, have more research-oriented projects, it's not that long. It lasts only 2 years. So we are now on the 2nd year, and by the end of 2022, we will be done with our project. And we had the budget of 2 million euros. Before I go to the aim of the project, I just want to make clear from the beginning that our project is not creating e-health solutions. So we are, this might be a bit boring, but it's not innovating in this way. It's not creating one more solution. Our project is trying to look at the framework around e-health, is trying to coordinate different actors, cooperate with different actors, inform them and strengthen their capacity to use e-health and also to make the right decision for e-health policy. So we try to learn from what is already been developed, from the mistakes, but also from the best practices until now. Try to systematize this knowledge, try to create database where actors, startups, or authorities will have access and can go and read information on how to make better e-health better, but also to with the final aim to improve health. So the common understanding for our partners is that e-health is not a goal in itself. We want to have better health, and e-health is the means to succeed it. So to go back to the aim of our project, Better Health, is to increase the level of international cooperation in e-health, inform and strengthen end-user communities and policymakers in making the right decisions for the successful implementation of e-health. We also try to create opportunities for stakeholders in Africa and Europe, and towards the overall aim of better health outcomes through better healthcare accessibility and higher quality. It all started with a call from the European Commission, as I said, where they were demanding, the title of the call was supporting deployment of e-health in low and lower and middle income countries in Africa for better health outcomes. And they were requesting a registry of relevant existing e-health solutions, to also look at the existing strategic partnerships in e-health deployment, also higher level of that the project that would be funded would contribute to higher level of international cooperation and networking, and increased opportunities for e-health innovators, patients, medical staff, and health system stakeholders in Europe and Africa, and of course better accessibility of e-health services. So the call was that from the European Commission, and then our group of partners got together to write an application, as is usually done, how these challenges can be solved. And also our concern was also how, in addition to these challenges, in parallel, we could also be as useful as we can for e-health stakeholders, of course, including patients in Africa. And this is the concept that we concluded. We organized all the factors that they can improve e-health, not only in Africa, but let's now focus on Africa, all the factors that contribute to better e-health that should be included also in the policy documents or the national strategies of the countries. So we have, as a first step, is that we should look at what is already done. So we have we have already many e-health solutions developed. What about building a registry of e-health solutions, but also building a registry of e-health policies to see what the African countries have as policies in e-health, and which of them are also similar, which to some extent we can also see which of them have been successful. This means that, okay, we also look at the existing research. We have done some also reviews that we will publish on research priorities in health. So we're trying to see what is already there, more as a review or more as a mapping of the landscape there, but that we will also publish for others so they can use the same knowledge, but also access the same data so they can produce their own knowledge. When it comes to the registry of e-health solutions, I just want to point out that in addition to the efforts we do, we see that there are efforts on two other levels. One is that it's a trend in several, or in some, let's say, African countries, maybe in other countries too, beyond Africa, to create their own registry of e-health solutions for the national level. And the purpose for that is that they might use it for accreditation, certification, licensing, but also to have an overview of who is operating in those countries. We are trying to work with this level. We're trying to get experiences for them, but also share our experience with them. And then we see one level above our level, which is the WHO, the World Health Organization, that is creating the Digital Health Atlas. And we are also collaborating with them in order to get data from them, but also give them our data once we have collected, because we see that with focus on Africa, we have more solutions and more people working collecting data that we can update their database. So in collaboration with WHO, we're also trying to think beyond our project as a sustainability solution or exit strategy that after our project, after the future projects we will have, hopefully, we will be, our data will be reposited at the Digital Health Atlas for more people to access over time. So on the one hand, it's like the research and the existing solution and policies. On the other hand, we have the human factors, which in eHealth is also very important. We see that in Africa, but also all over the world, a main barrier is the low technical literacy when it comes to the use of the eHealth solutions. So, but also we see that there's a need for capacity building in using eHealth, but also creating health solutions. And also from the side of the health personnel, knowing what to demand when it comes to health solutions. And the same goes to patients, building capacity for patients to know what are the rights in eHealth, and that the main focus, as it is in health, should be them in eHealth solutions too. So we have partners that they have a lot of activity in capacity building in eHealth, and we also continue building partnerships and activities related to that. And very related to that is also the empowerment of the stakeholders to have a voice in eHealth. This is, I think, a good example from Norway that can be used in other countries, that when it comes to eHealth, stakeholders in eHealth, whether it is patient organizations, whether it is professional organizations, doctors organizations, nurses association, many groups, many stakeholders are involved in the formulation of eHealth policy. And this is something we're also trying to build in our partner countries, to include them and also empower them to take a stand in building better eHealth policies. Then it comes another group of factors, which is very central in Africa, and it's the technical factors. And of course, it's also something new. It's the interoperability, it's the standardization, but also the technical infrastructure that needs to be in place. And technical infrastructure, it is a great challenge in many African countries. But also we'll see that it's also an opportunity, since they don't have the traditional networks based on cables, but they have already built their new solutions on mobile networks or satellite solutions. So we also do systematic work in this towards those factors to try to we don't solve these problems, but we look at existing challenges. We try to systematize and list them, and see also if there are some solutions or if there are organizations that work systematically this solution. This goes to standardization and interoperability. It's not us that we will solve this problem. It's us that we will help stakeholders see the right direction. And then it comes to the public policy factors. That is also somehow all these other factors also end up here, but there are also issues that are unique for this, like legal issues and registration issues and financial issues. We see the special challenge of African low and lower middle income countries to depend on donors, to not have often a saying on how the money in health will be used. So investments are decided by donors on often their view of the needs, which is also something that is based on facts. But we also see that many ministries of health also see it as a barrier for making decisions that are good for their healthcare system. The other problem related to financial issues and donors is that we also see that different donors have different priorities or different choices when it comes to the healthcare e-health solutions that they will invest in. And this has been also a discussion with some Ministry of Health that they would like, for example, Better Health or other initiatives to help them coordinate all the donors in the to accept that they have to invest in the same e-health platform. For example, eHelse that is commonly used in many African countries. So our project is combining all these factors in creating a roadmap for e-health policy, and then that hopefully will be common for our partner countries, but also for more for other African countries, and then in 4 strategic implementation plans, because it's mainly 4 countries that we collaborate with, and we have partners from. It is Tunisia, and it is Ethiopia, Malawi, and Ghana. And I will also present the partners from these countries, but also these countries, our partners in these countries, have also a goal to become a regional hub for e-health for those for the regions around them. And this is why they're also distributed in the 4 regions of Africa. We have Tunisia in the Northern Africa, and we see that they have built a very wide and strong network with other partners and stakeholders from the Northern African countries. We see Ethiopia, that is 2 universities there, also covering the Central and Eastern Africa, and we see Ghana in Western Africa and Malawi in Southern Africa. And to present our partners in this project, we have SFAX Health Tech, that is a health tech cluster from universities and hospitals and startups and companies, many e-health stakeholders from Tunisia in SFAX. We have the Ghana Health Service in Ghana that is associated with it belongs to the Ministry of Health in Ghana, that is the implementer of policies, of health policies in Ghana, but also the primary health care actor, main provider of primary healthcare services in Ghana. And we have 2 universities, the Zima University from Ethiopia and the University of Gondar, also from Ethiopia, both with also long history of collaboration with Norwegian universities and institutions. We have HIS Malawi, that is working closely with the Ministry of Health in Malawi for the implementation of HISP and DHS2. So it's more like an SME consultancy for the Ministry of Health. And we have Center from Norway. We have the Norwegian Center for e-health research, that is also a WHO collaborating center for e-health. We have the University of Southeast Norway, that is one of the partners that has a lot of experience with capacity building activities in Africa. And we have the University of Oslo, of course, capacity building, but mainly the DHS2 development and coordination all over the world. And we have 2 SMEs, one from Belgium and one from the Netherlands, that also help us with communication. What we've done so far, we, as many other, or all the world, I guess, were affected by the COVID-19 pandemic, and many of our activities had to start to be digital. Fortunately, now we start meet physically also. We start to organize our meetings, face-to-face meetings and workshops. And it's really, I have to say, even though I believe in e-health and digital health and interaction, also the face-to-face has its own value. But we managed to collaborate for 1.5 years or maybe 2 years, working also on the application digitally or hybridly. We have very often meetings, but the most important is that through these digital meetings, we managed to build a network. We managed to collaborate between those countries, or with between the African countries and the European partners, and advanced for the different targets we have in the project. We built this registry for eHealth solutions and the eHealth policies that has more than 170 solutions now, and around now I don't remember the number, but several eHealth policies from all over Africa. And the difference from other registries is the quality review process that we have. So it takes some time for us to publish the solutions and the policies on the website, but we make sure first that the information that is there is quality assured. As a result of not having these physical meetings, we also built this community, as you can find on this website, community.betterhealth.eu, where we try to build a meeting place for eHealth stakeholders, that they can have their own meetings with each other, they can book meetings with each other, there is also a marketplace where they can present their solutions. I guess you can, Sirena, you can go there and register and also write your solution and meet with other stakeholders or other entrepreneurs from Africa that they have similar solutions in other countries, and collaborate with them. And through this platform, we also deliver regularly webinars on issues that are related to our project, but also relevant for eHealth stakeholders. We also, through the deliverables we produce, as I said, we built this registry of eHealth solutions. We built this registry of eHealth solutions. We have written some reports on what we find on best practices when it comes to eHealth solutions, but also best practices when it comes to eHealth policies. And we also have done a mapping of the stakeholders in Africa, in the 4 African countries, and how they participate in our in the formation of eHealth policy. And this also indicates where, in the future, which actors should be more actively involved. And if you make a guess here, the actors that are not involved here are the patients. And we see that there's a lack there. There maybe not be a tradition for patients to be involved, or not so a strong patient organizations, but there is a lot of space there we see that there is a need, and this is one thing that could improve eHealth policy, or many things that need to improve eHealth policy in Africa. But one of the things is also the involvement of patients, the involvement of healthcare professionals, but also the involvement of private actors. We have also produced deliverables where we summarize interoperability and standardization and technical infrastructure challenges, and also organizations and collaborations that they have come up with suggestions there. And as I said, we are now in the creating the roadmap for the health policy, where we try to combine all this information we have already gathered to a document that can guide a specific strategic implementation plan that we hope that the different ministries for health and the eHealth stakeholders in each country that participates in project, and hope in other projects in other countries, will use to improve their future eHealth policy and national programs. There are many things we've learned through this project. It's also difficult for one person to have, because we have very active African partners that lead these activities. So this is another issue with the project, that maybe someone wonders why a project about eHealth in Africa is led by a European or a Norwegian organization. The very easy answer here is that it's a requirement by EU that project, even if they're in Africa, they will be led by an organization in Europe. But the truth is that we coordinate the project, but the 5 partners in Africa, they are very central in creating, producing this knowledge, formulating the project, improving the project, making suggestions, making sure that when we have a contribution by a European partner is relevant for the local context But we, the European partners, see our role very clearly that it is to support those partners in creating, producing knowledge, producing, organizing networking activities that are relevant for them. But we also see that there is not only experiences from Europe that can be used in African countries. There is several experiences from African countries that can be used in Europe. So what we learned is that we have many common challenges, both across the African countries. We see that we need vision that is not usually there in these countries. Political actors or the Ministry of Health need to have a vision on how they want eHealth to help health, what is the main goals. We see that we have limited resources. We see that we have infrastructure problems. Sustainability is a challenge. Low technological literacy for the healthcare workers and the patients that are using that we expect that they will use these health solutions. We have many regulatory challenges. We have problems with the standardization. There's not how's it called? It's not forgiven that everybody will comply with that. There are silo solutions there that they don't communicate with each other, even though there would be a large benefit from that. But the good thing is that when we have common challenges, we can also use similar solutions. Not exactly the same solutions, but to some extent can be very similar. So we can join forces, and that's our project is doing, and we can learn from each other. Yes, thank you.
Thank you very much, Kostas. Even I've heard some of your presentations before, it's always impressive. I'm so impressed to hear what you have achieved. This has been 4.5 years ago you started the project, and all the results you have got so far. And it's a short time project, it's 2 years. So how can we make sure that the good result that you have been building now is being brought forward into the future and benefiting in the long-term run? Because what you have achieved so far, I think is just brilliant. So how can that materialize in the future?
This is a challenge on which we will focus now the last 6 months of the project, our exit strategy. And we have partners, especially the African partners, that are very interested to continue working on these activities. We see that around these partners, there are other stakeholders connected to these regional hubs that they are even pushing them to organize better these regional hubs, to organize more activities, to think beyond the 6 months of the project. So to be honest, this is the driving force for me to also continue working with that and try to maintain this network of partners and a network of people for future activities. So we are in a situation now we are looking for new funding opportunities. We have partners that we have worked with in several applications for research projects. So this has been also a platform for new applications to be built, new collaborations. We also see that our role is sometimes also to connect our African partners with Norwegian or other European actors, and the other way around. When we have projects in that we would like applications that we'd like to think in these African countries, we also have seen that it's been very useful to use this network to find other African partners there. And this is also something that I would invite more European partners or European actors to do. They could contact or they could use our network to find reliable, hardworking, very, how can I say, partners in Africa.
Yeah.
But it's, as you said, it's a lot of results we have done. It's the African partners that produced the main body of this knowledge, and they've carried this project forward, and they're also very interested to make use of the results, but also continue working on similar activities.
reflecting the COVID you started and 1.5 year, I think still it's really achievements you have got here. So and for me it looks like the kind of regional hubs that you are doing in Africa seems to be also a successful approach to have these hubs around distributed in Africa.
And it has been also very interesting that they take a different form. Not all of them look the same. We see now, I've been to the regional hub meeting of a workshop of Northern Africa, and we see the partners there. They come from Ministry of Health, they come from other organizations, from hospitals, from many different eHealth actors. We see that maybe in the regional hub for Western Africa has a slightly different nature, more focusing on governmental actors. So we see different regional hubs. They are interested to continue working with this as a connecting hub where they distribute knowledge from our project, but also they collect knowledge about the surrounding countries towards the project. But they're also interested to continue with their own activities and organize their own events and meetings.
Yeah. Thank you very much, Kostas. It's been nice to hear. So now we have heard from vi har hørt fra gründere som har helt konkrete produkter, og opp til prosjekter som har politiske føringer og kan sette politikken i de ulike afrikanske landene. Så jeg synes det er imponerende å se at norske og aktører som kan være små med gode ideer, flinke fagfolk, adresserer globale utfordringer på den måten som vi har sett her i dag. Og andre prosjekter som da samler disse utfordringene og tar det opp til det politiske nivået. Så på denne timen så er jeg ganske imponert over hva som vi har hørt her i dag, og hva som forhåpentligvis kan bli resultatene i fremtiden. Jeg skal bare sjekke her om det er noen spørsmål. Foreløpig så har det ikke kommet inn noen spørsmål. Dere er suverene på hvordan dere presenterer og gir innspill. Er det noen som har spørsmål til Kostas i salen? Nabil?
Thanks, Kostas. Really nice presentation and really interesting project. To which level has the network succeeded in, for example, replicating or maybe expanding one of the successful eHealth solutions from one country to another or to other locations? I would say that it wasn't our goal to replicate solutions. So we, even though some of our partners have the technical background, or some others have the political background to implement the best practices, it wasn't the goal of our project. And also I would say it's early because now we are finalizing this, best practices. So hopefully it will be the next step that our partners, or in a future project ourselves or others, because all the knowledge we produce will be publicly available, will make use of the results.
Flere spørsmål? Ta en liten titt her igjen. Nei? Jeg har noen flere. Tusen takk, Kostas. Jeg har noen flere spørsmål til de andre foredragsholderne, hvis jeg kan komme med det. Som gründere, og med fantastiske produkter og ideer. Og det er en ganske utfordrende situasjon å være i. Dere har fagkompetansen, og dere har gründerkompetansen. Og hva det viktigste aktørene som dere møter, og hva kan norske aktører som eventuelt sitter og hører på, så hva kan de bidra med? Hva hindringene som dere møter, som dere ønsker støtte til? Dette trenger vi mer støtte til. Disse aktørene, samarbeidspartnerne, trenger vi for å komme til det neste skrittet. Har dere noen tanker om hva trenger dere for å komme videre og få alle disse ideene helt ut i siste ledd. Vær så god, Nabil.
I take it in English.
Yes, please.
I think what Norway need to invest more is more innovative solutions, which what we are doing actually.
Yeah.
Norway has a very nice strategy that, okay, now it's time to come with new out-of-the-box ideas. That's where we need to motivate startups like our company to do and to take the risk. Without the support of the government, without the support of the big funds in Norway, we will never dare to go into risky innovations. The more you or Norwegian government, Norwegian authorities support, the more they invest, the more we are able to challenge ourselves and to go into new things.
Yeah.
So I think the main probably issue is the fund actually,
Yeah.
or one of the main issues.
Yeah.
At least.
So it's flexible funding
Flexible
strategies.
funding, and to be a bit more brave to say that, okay, go for this risky business. It's there's a chance that we might fail, but that's completely fine. It should be completely fine.
Yeah, and if it's innovation, it has to be a risk factor.
Certainly.
Because if it's not a risk factor, there's no innovation. So I think that's in the nature of a product like that. So if you know the end result precisely, it's not innovation.
Certainly.
And it's not implemented until it's in use out there. So it's a long way, usually from the perfect lab to prototyping to the real product out in the field.
Maybe
Serena, have you some comments, ekstra kommentarer til
Ja.
Nabil?
Ja. Nei,
Råd?
jeg er enig. Jeg synes Norge er flinke på å løfte fram mennesker som har ideer, og bare å bli invitert til sånn som dette her i dag, gjør jo at vi som har tanker når ut til andre som kanskje har gode innspill og råd, så jeg håper virkelig at noen av de som har fulgt med i dag tar kontakt, sånn at vi kan samarbeide mer og utvikle ideen videre. Selvfølgelig så er jo økonomi en stor del, så det å få funding er jo en viktig del når en skal utvikle et produkt. Vi har en søknad inne hos Innovasjon Norge nå, for eksempel, som vil jo være betydningsfull hvis vi får det. Og så er det jo også det at en har lov å tenke stort. En plass må en idé starte, og at en liksom ikke blir begrenset av at ting virker umulig, da. Fordi det kan faktisk også fungere med nok hoder på plass og samarbeid.
Og det jeg opplever fra dere er jo at dere kjenner behovene godt. Dere vet, har god kunnskap om hva som er behovene, så dere kan være ganske målrettet i tilnærmingen deres når det gjelder produkt. Hva er det som er viktig i de landene dere skal implementere? Hva kanskje er hindringene, eller hva er det økonomien der også, eller er det samarbeidsrelasjonen, eller hva er det som er viktig i forhold til de landene dere skal pilotere? Nabil?
For us, we have two partners in two different countries, and we tried our best to make to choose different type of partners. So in Ethiopia, our partner will be more like a research group. So this will help us to improve or to finalize the prototype and to make sure that, okay, we are completely fine. We can now go for a clinical pilot study. Our second partner, it's the Ministry of Health.
Yeah.
So it's really clinical. It's really a way for us to say that, okay, now we are sure that our product, our device is able to cover the need and to provide a tool that is affordable, that is reproducible, that is easily used at the national level. Yeah. So there are certainly challenges. We have not started, so we are not sure, but we foresee that there will be some challenges related to some ethical issues, to some technical issues with the infrastructure, with the expertise, with these things. But I think in general, cooperation between European and African countries, I think we should be able to face these challenges.
Yeah, and also very key, as you said, to have different types of stakeholders in the different countries, so you can have more stakeholders to collaborate with.
Certainly.
Yeah.
Yeah.
Do you have some extra input, ekstra ideer, Serina, sett fra deres ståsted?
Ja, vi skal jo starte med å jobbe med helsemyndighetene i Tanzania, og selvfølgelig det er jo en utfordring å få de til å ønske å investere i dette for å nå ut til sin egen befolkning der ute på landsbygdene som kanskje ikke har blitt nådd. Så det gjelder jo å få til et godt samarbeid der, og at de ser verdien av at dette vil være kostnadseffektivt og positivt for deg selv og for landet, og at det kan være altså, vi håper jo at det blir bygd sykehus og klinikker rundt overalt også, men dette kan være et bra supplement, både i mellomtida og samtidig som ting kommer opp. Det trenger ikke være bare en erstatning, men også et supplement. Så det er vel det som blir utfordringen nå, å få til et godt samarbeid der alle parter ser at det er en verdi da, å bli med.
Og dere har jo allerede en samarbeidsavtale på plass før, så dere har jo et godt grunnlag.
Ja, og så kan jeg jo også si at vi har også lagt en avtale om kompetanseoverføring, for det er veldig viktig for oss at det ikke skal være noe å komme med et vestlig produkt og skal fortelle mennesker i Afrika hvordan de skal gjøre ting. Det er veldig viktig at dette er et samarbeid, og det er de menneskene som jobber med helseutfordringer i de forskjellige områdene som skal få være stemmen som sier dette er vårt behov. Ja, og når vi sammen bygger opp den teknologien, så skal den kompetansen ligge i de afrikanske landene også da.
Flott. Ta en liten titt til her. Fortsatt stille på spørsmåls... Hva sa du? Ser rolig ut. Da har jeg et spørsmål til deg også, Kostas, hvis har dere noe oversikt over, det er kanskje litt teknologisk, men har dere noe oversikt over tilgang til internett, tilgang til teknologi? Du snakket om digital literacy. Kan du si litt mer om det, og hvor utbredt det er? Vi har jo hørt fra noen av de vi har samarbeidet med på Basic Internet Foundation, som Josef Noll sier, the boys have the toys. Har dere noen tanker rundt dette med tilgang til digitale tjenester og internett?
I don't have the statistics now, but I just want to confirm what you're saying. Even though we see that there is access to many places, there's also areas where there are problems, there's instability. Also, for some e-health solutions to work, you need, in addition to internet, you also need electricity, and this is also another problem. And so there is challenges related to that too. The cost of access to internet is also a barrier. We've seen it with our partners when they have to go to do field work. Sometimes they also don't have access, or over several days they cannot answer their phones or get emails. So I guess this is also our experience that confirms the statistics.
Yeah.
And then on what you're saying, of course, there is another issue. As we go to digital health, we try to have it as a solution, e-health as a solution for accessibility and quality of services. But on the other hand, we might face problems, as you mentioned, that there might be divide related to AIDS, related to gender, related to also income. So those are issues that there are. The good thing with our project is that we can include them in the policy, e-health policy suggestions, so they will be also considered by the politicians as the country is investing more in e-health or directing their investments in e-health. So that's we hope that by making aware, raising the awareness about that this might be a step in the right direction.
Yeah. Thank you very much. I'm delighted to hear, and I'm so proud to have colleagues and here in Norway that are working on such important project, lifting it up from technical solutions up to address the major UN Development Goal number 3 on better health, access to health.
Can I just have 2 comments from also what I heard.
Yes.
And also the one is related to the fact that we're talking about the Norwegian ecosystem or the Norwegian contribution to global health. And in Better Health we have 4 Norwegian actors. It's the SINTEF, it's the University of Oslo, it's the University of Southeast Norway, and the Norwegian Center for eHealth Research. And that is one concern we had when we were applying for this application, that 4 out of 11 partners in the application would be seen as negative and with really high costs when it comes to personnel. On the other hand, we were the only application out of 28 from all over Europe that was financed, which means that despite all these high costs, Norway has a lot of activity in global health and in e-health, and this is noticed maybe, and also something we can make more use of. Each of the partners in the project had an important role. University of Oslo with DIHS2, Norwegian Center for eHealth Research being the first WHO collaborating center in eHealth. SINTEF with activity also and your previous projects, current projects and other colleagues, and the University of Southeast Norway with a lot of activity in capacity building was the strength for applications that we should make use, and others also make use of this maybe reputation or resources that we have here.
Excellent. Så jeg tror vi har vist at innovasjon og e-helseløsninger virkelig kan bidra til å oppnå bærekraftsmål nummer 3 og bedre helse i en global setting. Nå har vi fokusert på bistandsarbeid og lav- og mellominntektsland, men også vi tror at mange av de løsningene fint kan brukes også i norske settinger. Vi har jo et ganske langstrakt land, så e-helse jo også et aktuelt tema i Norge. Så langt så ønsker jeg å takke dere for fantastiske presentasjoner og interessante bidrag, og gi dere en bitte liten oppmerksomhet på veien. Takk. Takk for bidragene. Tusen takk. Tusen takk for bidragene. Takk skal du ha. Så, enjoy. Tusen takk. Så skal vi ha en liten avslutning her med litt reklame for FTU på slutten. Så tusen takk til dere. Hvis du kan steppe fram litt lenger fremover. Ja, det jeg som gjør det. Sånn. Litt reklame til slutt for FTU. Vi et lite forum, men interessant forum opplever vi. Og ønsker at de som har lyst til å bli medlemmer, kan få personlig medlemskap, det studentmedlemskap og det institusjonelle medlemskap. Og det koster ikke all verden, det 200 kroner for personlig medlemskap. Så gå inn på nettsidene hvis dere ønsker å bli medlem. Dere hjertelig velkommen. Så til slutt så vil jeg si tusen takk til Nabil, Serina og Kostas igjen. Og tusen takk for oppmøtet, og takk for fantastiske presentasjoner. Takk for i dag, og vel hjem.